And you're wondering, why does the scanner do this? Why is there so many intersections? This is obviously not real life because the patient's teeth don't magically go through each other.
Hello everyone, thank you for joining us today. My name is Jenny and I'm a part of education team at Medit. Nice to meet you everyone, and today we have Dr. Ahmad here.
Hey guys, how you doing? Welcome everyone.
How are you, doctor?
I'm very well. How are you doing, Jenny?
I'm good, thank you for asking. Okay, so I think today's topic seems really interesting because it's about occlusion and it's a key part when it comes to the end of restoring prosthesis.
I agree 100%. I think bite scans, recording occlusion is a critical part in the entire process, especially when we're sending things out to the lab. And I think it's a part that needs a bit of clarification and a bit of troubleshooting, as I see many users having some issues.
Yeah, we are very excited to hear about your clinical tips and experiences about recording occlusion.
All right, let's jump into it.
Okay, sure, being doctor.
Let's make a start. Big welcome to everyone joining us on this Medit webinar. Once again, Dr. Ahmad Al-Hasni here with you. And today's topic is recording occlusion. And what I wanted to do is share a couple of tips and tricks and just go over how do you correctly record occlusion and all the little troubleshooting issues that can happen and, how to solve them and fix them. So, of course, if you've been watching the Medit webinars, I'm sure you're sick of me introducing myself. But for those of you who are new and those of you who have been watching, big welcome to you all. My name is Dr. Ahmad Al-Hasni. I'm a full-time general dentist in Wellington, New Zealand. I'm actually sitting in my clinic right now. This is not a green screen. And yeah, I've been involved heavily in dentistry and especially digital dentistry for the past 8 years. Me and my father and my brother, we own and operate 39 dental clinics in New Zealand. And so we're all really into dentistry. It's a big passion of ours. And this is a picture of one of our clinics here in Wellington, New Zealand. We also run a lab, a full digital lab called IDD Lab. Of course, many of you may have heard of IDD, which is the education platform I run. And through our lab, it's very interesting because I actually see a lot of the occlusion issues. So our lab gets a lot of scans from outside and outside our own clinic, should I say. And we see a lot of the issues. And even within our own clinics, within our associates, and even myself, I have occlusion issues occasionally. And so it really makes me reflect, how do we catch these before they go to the lab? Because I can tell you guys, the lab team doesn't want to see it. So as mentioned, I've been using scanners for a very long time. I basically use every single scanner on the market, and I've been scanning for the past, I would say, since graduation, so 8 years. And there's never really been a case where I needed to pick up PVS to take a bite. And I strongly believe all occlusal issues that may arise when scanning can be fixed. And I wanted to go over that. Now, when we think of occlusion, it's a very, very broad and big topic. And I don't know about you guys, when I think of occlusion, I think of full mouth rehab. That's the first word that comes to my mind. And kind of when someone says occlusion, I instantly think of this sort of treatment, which is honestly one of the most satisfying things in dentistry. But we're not going to be talking about that today. We are going to take a step back and go right to the basics. And for those of you who are listening who already do this day in, day out, I apologize. This may feel like too basic, but you may pick up some key tips and tricks along the way that, we all have our own ways of doing things. And so occlusion is exactly this. As Jenny said at the start of the webinar, it's a critical part of the entire process. The reason why it's so critical is this is the data that you're going to give to your lab. And so if your occlusal data is wrong, you really will have issues with your final prosthetic. Now, oftentimes labs will correct any issues. They will correct it using software like Exocad and stuff like that, but you don't really want to put it in the hands of the lab. You just want to capture what's real life correctly. Now, I want to start really basic, and then we'll talk about the troubleshooting, is how do you take a bite scan in the first place? And I know this may come as, logic to a lot of people, but some of you who are new to scanning, some of you who may not even have a scanner to begin with, may be wondering. And so you take an upper arch scan, you take a lower arch scan, whatever your prosthetic is, implant crown, single crown, bridge, whatever it is, splint, it's always the same. The workflow is upper arch scan, lower arch scan, or vice versa. And then you move on to taking a bite scan. Now, I just want to make something really clear, guys, is that a bite scan, as you can see here with this gray shadowing, is just like your upper or lower scans, except that the software is going to use it to align the upper and lower jaw scans. So it's really critical how you approach this and where you start. And one thing I really want to make clear, guys, is for basically all bite scans that I do, I always start as posteriorly as possible. And one little tip I like to share is, because I see this with a lot of newbies to scanning, is that don't start the scanning button before you enter the mouth. You want to move into position and then start the scanning button and then start taking your bite scan. Because if you start the scanning button outside the mouth and you're trying to move into position, it's really likely you're going to capture like some of the lip or something like that. So you move into position, start the bite scan, and you want to be as posteriorly as possible. Usually around the 6s is enough, around the 7s. And you want the scanner to be basically facing the occlusal table, perpendicular, right facing the occlusal table. And what you then do is you move forward, you move anteriorly. While moving the scanner, you're almost, bodily movement of the scanner up and down as you move anteriorly. And the reason why you do that is in that little window of the scanner, you want to capture both the upper and lower teeth while they're in occlusion, and also 1 millimeter, 2 millimeters of the gingival tissue, because that is going to give you your most accurate bite scan. And as you move forward, you may notice the software brings the teeth together. And one key tip is that I would give it a little bit more data. I usually like to bite scan 4 or 5 teeth, so typically up to the canine. And it's really quickly, guys, you shouldn't be spending more than 5-10 seconds on this. And the other thing to realize is that, on the contrary, not only should you give it more data, I don't think you should give it too much. I see a lot of people constantly going over the same area. Once it is aligned, you can give it a little bit more, maybe a few more teeth anteriorly, and then stop. You don't need to keep, ironing the area, as I like to call it, where people keep going back and forth. So to show you this in practice, this is what it looks like, guys. And the Medit software is really cool. It has this 2-color effect where initially it goes this light green and then it goes this dark green. And I'll play this again for you guys. As you scan, you'll see that it's gray, and this is what the software is capturing. It will go light green when one arch is aligned, and then it will go dark green once the other arch is aligned. And that's really what you want to aim for, and it's usually very, very quickly. Now, one thing about alignment of this sort of data, you can obviously do a manual alignment. I personally try to avoid that at all costs, quite frankly. I mean, I feel like the automatic alignment should be, as it says, automatic. And given, if you've given the software the right data, it should be very quickly. If you're constantly scanning an area and it's not aligning, it should, raise red flags for you and to start troubleshooting and thinking, why is this not happening? Now, before we get into talking about the troubleshooting, I'm sure you all know how to take a bite. It's very easy. Let's just, tackle the elephant in the room. To take an occlusal record correctly, you need to make sure the patient is biting properly. And I know it goes without saying, but this happens to the best of us. I've made this mistake. Everyone's made this mistake. Just really carefully check how the patient is biting, because as we all know, when the patient is numb, they can bite in really weird ways. I'm sure as dentists, we've all experienced that. You tell the patient to bite down and they do weird things like, protrude very far forward, etc., etc. And, this happens to us when you're in a rush, when you're running late and you just want to do it really quickly. You don't really pay attention. And it's really critical to know that if it's not the correct bite, everything's going to go wrong. The AI in the software doesn't magically correct the bite for you. And I love technicians. They cover our butts in a lot of different ways. But even then, they will struggle to correct the bite like this. Although some AI tools are coming out because this is a common issue. So the point is always check, always get the patient to bite down on their back teeth and make sure, and this is the terminology I like to use with my patients, is that bite on your back teeth and bite very hard. And that's when I take a scan. Now, then becomes the question, what else can go wrong? Apart from the obvious thing where the patient isn't biting properly, what are the 4 things that can go wrong with a bite scan? Because in my eyes, bite scans are pretty easy to do and they're pretty easy to troubleshoot. And really, this is the 4 things that can happen. And this is really the only 4 things you need to think about, in my opinion, when taking a bite scan. These are the things you need to check. Incomplete bite scan. And this is when you keep scanning the area and it's not connecting. It's not connecting the 2 arches. And we'll talk about why that happens. A completely wrong bite. Sometimes this happens. An open bite, if you're really not paying attention. And most importantly, last but not least, intersections. And I think this is where most people have a lot of issues. And what I mean by intersections is when you take a bite scan and the jaw scans are going through each other, which is obviously a big issue. So let's go over the first things. Incomplete bite scans. And what I mean by this, guys, I'll show you an example. You're scanning for a crown and you scan the crown really well and you're doing the bite scan and then it attaches the first arch. But then you keep scanning the bottom arch and you're going over it and you keep going over it and it's not attaching. Now, if you do this for more than 10 seconds, 15 seconds, and it's not attaching, I would suggest trying to capture more of the teeth, more of the gingiva, but more importantly, start to think about why. Why is it not attaching? Because the software is very smart and is very capable. Scanner software, it's been doing bite scans for years, knows how to do it. The first thing that comes to my mind if a bite scan is not attaching is there any interferences? Is there a lot of soft tissue covering that buccal surface that's trying to be aligned? And what I mean by that is that your bite scan is simply a still image, is how I like to think of it, of that buccal surface. And then the software is going to try align the top arch and the bottom arch to that still image. Now, if your top arch or bottom arch scans are not very good, then it's going to have issues. And look, I've dramatized this a little bit here in this video, and I'll show you what it's looking like. But I instantly go to check my scans. And this may sound or look ridiculous to you, but it's actually quite common when we're rushing, is that we don't actually capture enough of the buccal data. So if you don't capture enough of the buccal data, the scanner is going to completely struggle to align that bite. And that's really the first thing that comes to mind. If the bite scan is not getting done, I instantly go back to my scans and I look at the buccal side and I just want to find out why. Why is it not aligning? And in this example, you can see we just go back really quickly and nice and easily fill up that buccal data. And what you will see is that then we go back to the bite and it aligns the bite very quickly. So it's all about giving the software the right data. If it doesn't have the right data, it's not going to be able to do this properly. And so once we start the bite scan again, you can start just where you left off, and within a second, it captures it. And so that's what I would really recommend. It sounds elementary, but if you're ever scanning any bite and it's not getting aligned anytime, whatever you're doing, full arch, dentures, single crown, bridge, if it's not getting aligned, you basically don't have enough buccal data on your scans. That's usually what it is. And you would go back, rescan that area, give it a little bit more buccal data. You don't need to scan the gums like crazy. I would suggest just 2 to 3 millimeters, and don't even measure it. You don't need to overthink it. Just make sure you're capturing some of that surface, and that will completely solve that issue. Now, in some cases, it can be very, very hard. In particular, things like this, where patients have kind of like quite a short clinical crown. And another example of these sort of patients is mixed dentition patients, little kids. Some of you may be doing orthodontics and scanning children. You may find taking a bite is tricky because of this complete overlap. And my advice to you in these cases is when you're scanning, usually the maxillary arch aligns very easily to the bite scan, but the mandibular arch, you're constantly scanning and it is not aligning. And in those cases, I even tilt the scanner almost facing upwards towards the occlusal table, trying to basically capture as much data as I can of those crowns underneath the buccal cusps of the upper molars. And so you can do all sorts of tricks like that. And the point is that you just want to make sure that your upper and lower arch scans have enough scan data buccally, that you haven't had a patch missing or a big gap. And, we've all been there when we're rushing. Or you don't have a lot of soft tissue covering that area because that won't align properly. You want it to be clean data, and when you do your bite scan, you proceed and capture as much of that buccal surface as you can to align the scans. And in cases where there's a big overlap, you may even need to angle the scanner underneath those molars on the top arch. So incorrect bite scans are pretty easily. The second one is super easy to talk about, just a completely wrong scan. And this is kind of funny to me. I mean, I don't know how people pull this off, and it's happened to me. Look, guys, this just happens. I mean, don't stress, don't freak out. This just happens sometimes where the bite scan's all wacky and weird. And sometimes this is due to the software. Sometimes, I mean, these days it's actually quite rare. And oftentimes when I see this happening is when there's a lot of soft tissue interference. And if I'll give you guys a minute to think about where the soft tissue interference can happen, which can really muck up a bite scan. Because again, when you think about it, the software is just trying to align those two arches together. And if there's a lot of soft tissue in the way, that can basically freak out the algorithm where it's trying to put these together because it sees all these intersections. And most commonly, the areas you need to keep an eye on is two areas: the tuberosities of the upper arch, including like some of the buccal sulcus, and in the lower arch, you just need to keep an eye on that retromolar pad area. Many of you as dentists will know sometimes sevens are barely sticking out of that area. And when you're scanning it, you can capture a lot of the angle of the mandible, basically, not the mandible, but the gingiva above that, and the retromolar pad area. And so when you're capturing that, if you have these big wings of soft tissue, and I'll try to draw them here with a laser pointer, if you have these big wings of soft tissue here and a big wing of soft tissue here, it can also stuff up your bite. And this is something to keep an eye on. Now, thankfully, with the Medit editing tools, you can easily remove these. And in this case, I'm showing you, I wouldn't even worry about that. That is not big enough. But this is the areas to keep an eye on. Now, on the off chance that you get something like this, let's say you get a scan like this, what would I do? I would simply just delete the bite scan data and start again. That's all I would do, and reset the process to give it another set of bite scan and see if it's going to align it correctly. If it still doesn't work, because the first time I'll just chalk it up as a software issue. If it still doesn't work, then I would be looking very carefully at my scan data to see why this has happened. Then we have the open bite. So the open bite is nice and logical. This is where the bite is completely open. And once again, I've really made it dramatic here for you guys so you can see it. It's never usually this bad. But what you need to realize is that when you take a bite scan, the software is really smart, but it's not going to close the bite for you. And this is where it's really important to make sure that the patient is biting down correctly. And what I mean by correctly is nice and hard on their back teeth, and you check that. Before you take a bite scan, it's not a bad idea to look, retract the cheeks with a mirror and look down the buccal corridor to see they're biting properly. Now, I know there's two schools of thought about taking a bite scan. Some people say, tell a patient to open, move the scanner into the patient's cheek area, and then get them to bite and then scan. I really don't like that technique because if you think about it, put a scanner in your cheek and it's really uncomfortable. You can't really get your normal bite that easily because you're kind of worried about biting on this thing and it's like in your mouth. So I prefer to tell the patients to bite down nice and hard. And then I retract the cheek with a mirror or my finger and then move the scanner into place. And I always tell them to bite really nice and hard and remind them to keep biting on their back teeth. You don't want a chewing motion. You don't want anything like that. Just biting nice and hard. So the interesting thing is, I know I've made it very dramatic here for you, but it doesn't always have to be that dramatic. And if you're in a rush, you can miss things like this. That's why it's always good to move the scans and open them up and check it on the heat map to see where is the occlusion coming from. Because if you look at this image, you would think that this is, a pretty good scan, and on the buccal surface, it looks like it's nice and closed. But if I pair your attention onto the right-hand side, which is a cross-section of this area, this shows that the bite is actually open. And I would suggest that this happens very commonly. Very, very commonly, and it's sent to the labs. Now, the labs can close it up using software. Obviously, it's not going to be like a hinge movement like your patient's actual jaw, so you can introduce a lot of inaccuracies like that. So rather than do that, I would really suggest you make sure the patient's biting nice and hard. You take a scan and you check your scans. And really, this is the next point, is that you really need to inspect your scans. When you take a bite scan, you need to look at your scans and check them from all the different directions. Buccally is quite obvious if you've got a really big discrepancy, but the better view to look at them is when you open up the bite scans and you look at them from the occlusal view and you check it with a heat map. A heat map is a really, really useful tool to basically eyeball the arch very quickly. And if you see basically no contact at all on one side, you know that's probably an issue. Now, let's say you've taken this bite scan and you've identified that it's open. Again, the good news is it's no big deal, guys. It's no real reason to stress. You just reset the bite scan. So you can go down the bottom here, delete the bite scan, and then get the patient to bite down all the way properly. And then you will redo the bite scan correctly. And as you can see, as long as you do everything correctly, the whole alignment should be done within 5 to 10 seconds. This bite scan business should not take you very much time. Now, the last thing is intersections. Intersections are probably the most annoying thing with taking bite scans with intraoral scanners. And what I mean by intersections is this. So what you're seeing, guys, is a intraoral scan, two scans merged together, and you're looking at it from underneath. And as you can see, there's a gray scan and there's a brown scan down here. So this is one scan, this is the other scan, and you can see all these intersections. Now, this is a really frustrating thing with intraoral scanners because I don't think many people understand why this happens. And there's a lot of theories, and here's another example, a little bit more of a color example. So you can see we're doing this crown down here. We take a bite scan, and then we see all these intersections over here. And you're wondering, why does the scanner do this? Why is there so many intersections? This is obviously not real life because the patient's teeth don't magically go through each other. There's a lot of theories, guys, why this happens. Prevailing theory is periodontal ligament. As we all know, our teeth move. Our teeth move when we bite down. And if you want to feel that, you can just put your finger on your canine, your upper canine, and then bite down really hard. You'll feel it move. So this is one of the reasons why people think this happens with intraoral scanners, is that there's this periodontal ligament movement, especially in patients who have very bad perio. That's a whole different story. But in every day-to-day patients, any sort of movement, and you're capturing something static, and the software is just going to put it together. Now, thankfully, in this day and age, the software compensates for this. A lot of intraoral scanner software, including Medit, compensate for this because they can identify when there's an intersection and correct for it. And I think the first step into making sure this doesn't happen to you is just identifying it. And as I mentioned, inspect your scans. You should be turning them around and looking at them to make sure there's no significant interference like this. The other prevailing theory of why this happens is software algorithm. So basically, when you take a scan, you've got that one image. The software is now responsible for that alignment. Some software is better than others. Now, if I just show you what this looks like here, so the easiest way to inspect your scans is after you've taken a bite scan, just rotate your scan. And as you can see all this intersection, which immediately raises some red flags. So you can see on the side that we have scanned, which is down here. This is the side we've taken the bite scan. It looks okay, but then on the opposing side, you got all this intersection. And look, the reality is, guys, it's quite an easy fix in my point of view. I mean, this has been like this for the past 5 years with intraoral scanners. Again, some scanners better than others. And a lot of scanners put software in their scanner software. And they put AI, should I say, in their scanner software to counteract this. So how do you fix this? In my books, the first thing I would do is take bilateral bite scans. I mean, I'll show you this very clearly. So you can see we have this very clear intersection here. And the first thing I do is just make sure I take a bite on both sides. Oops, sorry, I just went back. Let me go back to that video. Right, so where were we? So we have this intersection, and we took a bite scan on one side, as you can clearly see. Now, the good thing about the Medit software is that it allows you to capture multiple bites, 2 off the bat, as you can see down there, but you can add as many bites as you really want, up to, I believe, 4 or 5. And so you can go to the other side now and retake the bite scan on the other side. And what you're going to see the Medit software do when you take 2 bite scans, and this happens automatically when you take 2 bite scans, is that it says optimizing mandibular, maxillary, and occlusal data. And what this software is doing is just looking at these 2 bite scans and ensuring the perfect bite. If you are finding you're getting a lot of intersections, I can almost guarantee it's because you're only taking a bite on one side. Now, I do a lot of quadrant dentistry. You can follow my Instagram, Dr. Al-Hasni, and that's my Instagram hashtag and my Instagram handle. And you will see I do a lot of quadrant dentistry, day in, day out. I don't take 2 scans for quadrant dentistry. But whenever I'm working with a lab, anytime it's always a full arch scan, and it's always 2 bite scans, because you're going to see after this optimizes the data, and I did pause the video, guys, it doesn't take this long. After it optimizes the data, I'm going to swerve around and you can see there's no more intersections. And so pretty easy fix in my point of view is that if you're getting a lot of intersections in your scans, A, should probably be taking full arch scans in the first place. And B, if you've taken a full arch scan and a bite scan only takes 5 to 10 seconds, there's really no excuse not to take 2 bite scans on each side. And then becomes a question, so there we are, we have the 2 bite scans, 1 on each side. Then becomes really the follow-up of that is what is acceptable? What is acceptable intersections? And I would say, guys, that something like this, as you see on the screen, I wouldn't stress over too much. I mean, I know it doesn't all look perfect, but 1 or 2, 1 and 1.5 millimeters is probably a-okay if it's tiny spots like that. But when you really have problems is when it's like this. If you ever see a scan like this, and let's say you're planning a crown here on the right-hand side, as you can see the preparation over here. So you got a crown there. And when this becomes an issue is that if your occlusal data is that wonky, it makes the lab really question the entire case, the bite. You know, maybe you're over occluded on this side and under occluded on this side. And so how are they supposed to create a perfect fitting restoration for you when the data is wrong? And so fundamentally, all you need to do is just look at your scans, and I think most issues can be corrected with just taking up a good bite scan on both sides and making sure there's no soft tissue interferences. Now, interestingly enough, because this was an ongoing thing with many users, Medit released an app, Medit Occlusion Analyzer. And they released this just quite recently, actually. I think early this year or late last year. It was a very recent app. And when you download this app, you will see it at the top of your app box, which is over here. You'll see the Medit occlusional analyzer. So when you open a case, any case that you've taken a bite for, you can click this button. And what this Medit occlusional analyzer does, it just gives you two things: a really quick report if you have any issues with this bite, and two, a opportunity to fix the bite manually. Now, I wouldn't rely on this, guys. I would just do this as like a plan Z, or get out of jail free card, basically. So when everything else has failed, you didn't check the scans and you let the patient go, this is the last option you have to correct this before you send it to the lab. Of course, you can keep playing with the manual alignment, but this is also a good opportunity if you have some questions or you're not 100% sure if the bite is correct. So when you start this app, immediately it gives you a report like this, automatically all generated by AI. And as you can see, this is what I was mentioning by the heat map, is that you can see that on one side over here, there's a lot of color. And on the other side, there's very little color. Now, this is going to be a really, really big issue for us if we're making a crown here, because if the lab matches this bite as we've set it, there's a good chance that the crown is high. And the other thing that it does is it gives you cute little intersections and all these tools to analyze the bite a little bit better. Do I do this? No, I don't do this every case. And really, you should only do this, I would say, if you have a big concern, but it's good to have this tool in here. As you can see with these intersection lines, if you look on the right-hand side, you can see there's clearly an intersection here. And that is obviously not how the patient's bite is. It also gives you some other cool views, and more importantly, an opportunity to fix this. You can realign the bite. Now, if you're not comfortable doing something like this, I would just recommend you send it to your lab and inform them, because the lab, I promise you, is more confident and experienced with fixing these issues, because I'm sure they face it every single day. There's also a lot of AI tools coming out where I think they're just made for labs, really, where they can run a set of scans through an AI tool and it will automatically align that bite for them. So a big thank you for everyone. This is a big crash course on recording occlusion, how to record bites, how to troubleshoot the common issues that happen when we are recording these bites. So I welcome any questions, and a big thank you again for Medit for inviting me once again to these webinar series, as I love to share this information with you guys. How was that, Jenny?
It was really interesting, and I think it's covering really very common issue, but they were all very wondered about why it's happening, and I think you gave so good solutions.
My pleasure.
Enjoyed.
So we welcome any questions now.
Yeah. So today I have 4 questions. So I'll start with the first question. Okay, question number 1. Is there any clinical tip from your side to minimize occlusion assessment?
Yeah, so if I heard that correctly, occlusal adjustment. Yeah, and it's really just following the tips I shared in this webinar. To minimize occlusal adjustment, you just need to ensure that you're giving your lab the best possible data to work with. A lot of labs, they also don't want to, have the reputation that their crowns are always high or the crowns have issues. And it's coming back to the fact that if your occlusal data that you're sending to the lab, because you don't check it, if you just think you're going to scan this bite and it goes green and that's perfect, that's actually not the correct mentality, because the scanner will just capture the bite as you have it. So if the bite is open or closed or any issues like that, then you're going to be sending incorrect data to the lab, and that results in incorrect designs, incorrect manufacturing. That's all kind of a trickle down. So what I would really suggest is that when we take our bites, we check, make sure you've aligned it properly, and always check by rotating the scan that there's not a lot of intersections. And honestly, I just make it routine to scan both sides of the bite, and that solves most of our issues. If you do all of that and you're sure your data is correct and you're still getting high crowns, I'd have a chat with your lab and try troubleshoot why that is happening, because it also comes down to design and manufacturing.
Okay, thank you for answering that. Okay, question number 2. How do you take bite scan when patient has unstable occlusion due to tooth mobility?
Yeah, the bite scan and if patients have a lot of tooth mobility, that's usually, periodontally compromised patients. And if they've got really a lot of mobility, I would assume you're scanning for an immediate denture or something. But anyway, for the sake of the question, you use your standard tricks. If the patient doesn't have a stable bite, you make it stable. And so if the patient's really compromised periodontally, you can splint the teeth. You can do all sorts of other tricks to try and make it stable. If the patient's missing a bunch of teeth and the remaining teeth are not very stable, you can use things like bite splints and any sort of occlusal appliance that you can put in the mouth, like bite blocks, and you can scan those out extraorally, and then just like you basically scan a denture and then do the bite that way. In general, though, what I would usually do, if I have a patient who's very periodontally compromised, a lot of mobile teeth, and I'm planning for a denture anyway, I would just scan as best as I can at roughly the OVD that I want, and then handle the rest on the CAD side. So you can have that dialogue with your lab, because oftentimes you'll be changing the OVD if it is a denture. But yeah, typically it really just depends on case by case, and when in doubt, splint the teeth and make sure the bite is stable.
I see. It means you want to make the patient has the stable bites due to splinting it, and then you do your treatment. Okay. Question number 3. How do you set occlusion when patient has bruxism?
Yeah, so if a patient has bruxism, and I'm assuming it's kind of like that first picture I showed with the really aggressive, worn down teeth. It really just depends. It depends on what you're doing. If, let's say, the patient just wants a night guard, they don't really have really bad bruxism, then there's 2 ways of doing it. You can just take your normal centric relation bite or maximal intercuspation bite, so just get them to bite down, as we've discussed, and take a bite. Or you can put a leaf gauge in their mouth and take an open bite. And that applies to your full mouth rehab cases as well. So as I mentioned about open bites, the scanner software does not close the bite automatically. Now that may sound annoying, but it's actually very useful, because if you open the patient's bite, you don't want the software closing it, because you usually want to open the patient's bite to a certain amount to either do a full wax up if it's a full mouth rehab, or for a night guard appliance. And so typically what I'm doing for these patients, if I'm just doing some, crown, let's say, I will just use their normal bite. But if I'm doing something like a full mouth rehab wax up or a night guard or a splint, then I would be opening them up with a leaf gauge to the, degree that I'm happy with, and how far you open them up is a whole different discussion. And then get them stable on that leaf gauge and take that bite, and you will see the bite is captured open. And that's exactly what you want to give to the lab.
So do you consider about selecting materials as well?
Yeah, of course. I mean, if it's a bruxism patient, I mean, we could have a long discussion about different splint materials, especially with the new 3D printed splint materials versus nylon versus, and in restorative cases, yeah, whether you prescribe or subscribe to this 3D printing revolution that's going on, or you just stick to materials like zirconia, that's a whole nother discussion.
Okay, last question is quite long. So yeah. Question number 4. After recording occlusion, the color map shows that patient has bite, which is too strong, and sometimes it appears as if the upper teeth are passing through the lower teeth, which would not really happen in reality. So how many millimeters of collision should I compensate for?
Yeah, and it's like what I was mentioning, intersections is probably the most common area that error that happens with bite scans. And as I was mentioning, look, if it's a few little spots throughout the bite scan, I'm typically okay with this. But if it's a significant intersection, and you will see it, it's not about millimeters, but you will see it. If you just turn the bite scan around so you can see through it, or you can see through the underside of the scan, as I was showing you guys, and you see a lot of intersection, that is when red flags arise. And typically what I would do is rescan. If you've taken 2 bite scans and this is happening, rescan, just delete the scans and do it again. But if you've only taken 1 scan on one side, do the opposing side. And that's really the solution for most intersection issues that I find, especially recently because Medit released that mandibular and occlusal analysis that happens after you take 2 scans. This happens automatically and it helps reduce any intersections.
So you think that less intersection is quite okay?
Yeah, a little bit. I mean, if it's a little bit of spots here and there, I really don't find this to be super significant clinically. Of course, it's going to depend case by case, and honestly, have that discussion with your lab what they're comfortable with. But I don't really see these little tiny spots of intersection being an issue. I accept those. It's more so where it's like 2 millimeter, 2 millimeters, 3 millimeters, and an entire quadrant. That's when I see an issue.
Yeah, and also you explained that digital scan data and real impression is different due to PDL.
Yeah, big time. And there's a lot of movement in the PDL, as we all know. So there is that discrepancy that always happens with the scan data. But like I say, as long as you're doing scans on both sides of the jaw and taking full light, you shouldn't have any issues.
Okay. That's all about it for today. So you'll be able to watch this webinar on our YouTube channel at Medit Academy. Thank you for being here, Doctor.
Thank you so much, Jenny, and thanks again to the Medit team. See you guys later. Thanks for everyone out there watching.
Bye.